Imagine, just for a second, that you are tasked with performing this incredibly delicate, ornate embroidery.
Okay.
But there's a massive catch. Instead of using like a sturdy piece of canvas or denim, you have to stitch this complex pattern onto a sheet of wet tissue paper.
Oh, wow. Yeah, that's a nightmare.
Right. I mean, if you use the standard sharp needles and, the aggressive techniques that work perfectly fine on canvas, you are going to completely shred that tissue paper before you even finish the first stitch.
You destroy it. I mean, the structural integrity of the canvas, it dictates every single tool you can safely use. You really can't separate the payload you're trying to deliver from the architectural reality of the terrain you're delivering it to.
Which is exactly the entire mission of our deep dive today.
Yeah.
Welcome in, by the way. Today we are exploring the hidden science of tissue architecture.
Yeah, it's a fascinating topic.
It really is. Specifically, we're looking at how medical practitioners have to completely throw out their standard playbooks, right? Like they have to revolutionize their approach to hydration treatments when they move from the tough, structurally normal skin of, say, a photo-aged face to the incredibly delicate, compromised environment of atrophic mucosa, specifically in the vaginal and vulvar region.
Yeah, and that shift, it requires a fundamental change in medical philosophy because, treating that wet tissue paper is completely different. And today we're pulling from clinical injection protocols like the Deserial method, alongside some really fascinating dermatological research on the extracellular matrix.
And we've got some very specific gynecological studies in there too, right? Regarding the vaginal microbiome.
Exactly. We are really looking at the whole ecosystem.
Okay, let's unpack this.
Yeah.
Because before we can really grasp how practitioners change their physical technique to handle that, wet tissue paper, we need to understand the material they are actually injecting.
Right, because the medical compound itself doesn't change, only the delivery mechanism does.
Exactly. So we are talking about hyaluronic acid, or HA.
Yeah.
And I think when most of us hear hyaluronic acid, we instantly picture, like, cosmetic volumizing, right? Lip fillers, cheek contouring, that sort of thing.
Oh, totally. The aesthetic industry has definitely made that the most famous application. But in the medical world, there is a massive fundamental dividing line between two completely different types of hyaluronic acid. You have cross-linked and uncross-linked.
Okay, let's break that down, because I always kind of just assumed it was all the exact same gel in the syringes.
Most people do.
Right. So what does cross-linking actually mean in, like, a biological context?
So think of raw hyaluronic acid as millions of long microscopic chains, right? Just floating around independently.
Okay.
In cross-linked HA, which is what those volumizing fillers are made of, scientists introduce chemical binding agents, and the most common one is called BDDE.
BDBE. Got it.
Yeah, and this chemical essentially acts like a microscopic glue. It binds all those independent floating chains together into this highly stabilized, dense, three-dimensional gel matrix
But why do they need to glue it together in the first place?
to stop your own body from digesting it.
Oh, interesting.
Yeah, your body naturally produces these enzymes called hyaluronidases, and their entire job, their whole purpose, is to constantly hunt down and break apart hyaluronic acid.
So they're just constantly chewing it up.
Exactly. So the chemical glue in the cross-linked HA, it acts as a suit of armor against those enzymes. It makes the gel highly resistant to degradation, which allows it to sit in the tissue for, 6 to 18 months.
Which makes perfect sense if your goal is to physically prop up the tissue. It's like taking a couch cushion that has flattened out over time and permanently wedging a dense block of memory foam inside it.
Right, yeah.
The shape of the cushion changes instantly because you've added this structural volume that just isn't going anywhere.
The memory foam visual is highly accurate for cross-linked fillers, but the payload we are focusing on today, the material used in what clinicians call skin boosters, that's uncross-linked HA.
So no glue.
No glue at all. It does not contain any of those chemical binding agents. So without that glue, holding it together in a dense matrix, it is simply a highly viscous, free-flowing liquid.
But wait, if it doesn't have the chemical armor, won't those natural enzymes in the body just chew it up immediately, like we were just talking about?
They absolutely do.
Really?
Yeah, uncross-linked HA usually has a very high molecular weight. It's around 1 to 2 million Daltons.
Which is huge.
Right. It's a massive molecule initially, but because it lacks that cross-linked armor, the body's hyaluronidases break it down and metabolize it entirely in just 2 to 4 weeks.
Okay, see, this is where I'm getting hung up.
Okay.
If you are a practitioner, why would you go through all the trouble of injecting a treatment into a patient's tissue if it doesn't add any structural volume and it completely disappears in less than a month?
Uh,
Honestly, it sounds pointless.
I get why you'd think that. But what's fascinating here is that the rapid breakdown isn't a flaw, it is the core mechanism of the therapy.
But really, the breakdown is the point.
Yes, uncrosslinked HA isn't designed to be a static piece of memory foam. It operates on two distinct phases.
Okay, walk me through the phases.
So phase one is immediate, passive hydration. HA is a powerful humectant. A single molecule can bind up to 1,000 times its own weight in water.
1,000 times, wow.
Yeah. So the moment this liquid is injected, it pulls surrounding moisture in, creating this massive, temporary dermal hydration reservoir.
Okay, so it's acting like a deep conditioning serum that sinks into the fabric of the cushion to moisturize it,
Right.
rather than changing its physical shape.
Exactly. But phase two is where the actual biological magic happens.
Okay, I'm listening.
As those enzymes start chopping that massive 2 million Dalton molecule into smaller and smaller fragments, those specific fragments take on a completely new role. They become active biological messengers.
Messengers communicating with what exactly?
With your fibroblasts.
Okay.
Fibroblasts are the cellular factories scattered throughout your dermis. They are responsible for pumping out fresh collagen and elastin.
The good stuff.
Right. And on the surface of these fibroblasts are specific receptors known as CD44 and Rh receptors.
CD44 and Rh.
Got it. And the fragments of the breaking down HA fit into those receptors perfectly, literally like a key sliding into a lock.
So as the liquid degrades, it is essentially walking up to the cellular factories, unlocking the door, and telling them to turn the machines back on.
That's exactly it. It triggers a massive signaling cascade. The fibroblasts go into complete overdrive, spinning fresh collagen and rebuilding the extracellular matrix.
Wow.
So long after the uncross-linked HA is entirely metabolized and flushed from the system, the biological upgrade it left behind remains.
That is wild. The payload isn't just a moisturizer. It is like a set of blueprints instructing the body to physically rebuild itself.
It's biological engineering, really.
That is fascinating. So, okay, now that we understand the payload, let's talk about the logistics of delivery. How do practitioners actually get this free-flowing liquid into standard structurally sound tissue like a mildly photo-aged face or neck?
Well, you have to target the superficial to mid-dermis.
Because that's where the factories are.
Exactly. You need to deposit the liquid just barely beneath the very outer layer of the skin, because that is where the highest concentration of those dormant fibroblasts live.
Okay, so how do they do that?
The global clinical standard for achieving this with uncross-linked HA is a technique called NAPH.
Okay, so I was reading the clinical breakdown of NAPH in our sources, and frankly, it sounds incredibly aggressive for a treatment that is supposed to be about healing and hydration.
It sounds worse than it is, but the protocol involves taking an ultrafine needle, usually a 30 gauge or 32 gauge, which is incredibly thin, roughly the diameter of a few human hairs.
Still a needle, though.
True. And the practitioner systematically creates 20 to 60 tiny superficial intradermal punctures across the specific treatment zone.
Wait, they're essentially peppering the patient's face with dozens of microstabs.
Yes, depositing microdoses of the liquid at every single point, usually just 0.01 to 0.02 milliliters per puncture.
That is so small.
It is, and the practitioner actively looks for a specific visual cue. They want to leave little visible fluid-filled bumps, which are called papules, all over the surface of the skin.
They want to leave bumps.
Yeah, seeing those bumps confirms the needle is at the exact right superficial depth.
Okay, see, here's where it gets really interesting to me.
Mm.
I need to challenge this approach because logically it feels entirely backward.
How so?
Well, if the ultimate goal is to repair the skin and trigger collagen production, why in the world are we stabbing it 60 times and leaving it covered in visible welts? It sounds like we are damaging the exact tissue we are trying to save.
I know it sounds counterintuitive, but sturdy, structurally sound skin actually requires that specific type of microtrauma to optimize the healing process.
Really?
Yeah, human skin evolved to respond to injury. When you pierce the dermis with a needle, even a microscopic one, it triggers a wound healing cascade. Blood flow increases, platelets arrive, and growth factors are released.
Okay, so you are artificially sounding a biological alarm.
Exactly. And furthermore, fibroblasts are highly sensitive to physical tension. It's a process called mechanotransduction.
Mechanotransduction.
Right. So when you inject that tiny microbolus of liquid and create that visible bump, you are physically stretching the dermal tissue. The fibroblasts feel that mechanical stretch, and it essentially forces them out of their dormant state.
Oh, okay. It makes me think of lawn aeration.
Oh, that's a good comparison.
Like if the soil in your front yard gets heavily compacted and dried out, you can't just lightly mist it with a garden hose, right? The water will just run off the hardened surface.
Yeah, it doesn't sink in.
Right. You have to take an aerator machine and aggressively punch dozens of tiny holes deep into the dirt. You are technically damaging the lawn, but you are creating channels so the water and the fertilizer get trapped exactly at the root level, which forces the grass to grow back thicker.
The nappage technique is exactly that. You punch the channels, you induce a controlled microtrauma to wake up the cellular machinery, and you simultaneously drop in the HA fragments to provide the rebuilding instructions.
And the skin can handle that.
Oh, yeah. In sturdy, normal terrain, the tissue rebounds beautifully from that mechanical stress.
Well, that concept right there, sturdy terrain, that brings us to the central conflict of this deep dive.
Yes, it does.
Because we've established that normal skin benefits from this aggressive multi-puncture aeration method. But what happens when the terrain you are trying to treat is fundamentally compromised?
Right. And if we connect this to the bigger picture, we have to shift our focus entirely from standard dermatology to gynecology.
Okay.
Specifically, we need to look at a condition known as vaginal mucosal atrophy, which is incredibly common during menopause.
Right.
To grasp why the nappage technique would be catastrophic here, you first have to understand what a healthy, normal vaginal ecosystem looks like before atrophy sets in.
Well, you use the word ecosystem, and diving into these gynecological studies, it really is as complex as a rainforest floor.
It really is. The foundation of that ecosystem is estrogen. In a healthy premenopausal environment, estrogen acts as the master architect. It instructs the vaginal epithelium to build itself up into a thick, robust, stratified barrier, usually 2 to 3 millimeters deep.
2 to 3 millimeters.
Right. It has a basal layer at the absolute bottom, then parabasal cells, intermediate cells, and finally superficial cells at the very top.
So it is built like a thick brick wall to handle daily friction and mechanical stress.
Exactly. And under the continual influence of estrogen, those top layers of cells do something highly specific. They accumulate massive intracellular stores of a complex sugar called glycogen.
Okay, glycogen.
Yeah. As the surface cells naturally mature and slough off over time, they burst open and release all of that glycogen into the vaginal environment.
And, I mean, nature abhors a vacuum, so if there is an abundance of complex sugar just sitting around, something is going to evolve to eat it.
You're absolutely right. And that something is a highly specialized microbiome. In most healthy women, this environment is densely colonized by specific strains of bacteria known as lactobacillus.
Lactobacillus.
Right. Researchers categorize these into different protective communities, often referred to as community state types 1, 2, 3, and V.
Yeah, I noticed in the research they frequently mention strains like Lactobacillus crispatus or Lactobacillus in arcurs. What exactly are these bacteria doing once they consume the glycogen?
Well, they metabolize the sugar and they produce lactic acid as a byproduct.
Ah, lactic acid.
Yeah, and that continuous output of lactic acid is the crucial mechanism that drives the vaginal pH down to a highly acidic level, usually hovering right between 4.0 and 4.5.
But why does the body want that area to be so acidic? Like, what's the benefit?
It acts as an invisible chemical shield.
Oh, interesting.
The vast majority of harmful pathogenic bacteria and yeast simply cannot survive in a pH of 4.0. The lactobacilli are essentially engaging in competitive exclusion. They eat the food, they alter the environment to suit themselves, and in doing so, they protect the host from infections.
Wow, it is a brilliantly designed, self-sustaining biological loop.
Right.
The estrogen builds the tissue produces the glycogen feeds the lactobacilli, and the lactobacilli create the acid shield that protects the tissue.
It's a perfect system, but the clinical dilemma arises when a patient enters menopause or, experiences any other condition that causes a severe, prolonged drop in estrogen.
Because the master architect leaves the building.
Exactly. When estrogen leaves, the entire self-sustaining loop collapses.
Walk me through that biological collapse, step by step. Like, what actually happens to that thick brick wall?
Without estrogen driving cellular maturation, the tissue simply stops building the upper layers. The intermediate and superficial cell layers thin out dramatically, and eventually just disappear, leaving only the immature parabasal cells at the base.
So the whole structure shrinks.
Right. The robust 3 millimeter thick barrier shrinks down into this paper-thin membrane.
And because those upper cells are gone, the glycogen they were storing is gone too.
The food source completely vanishes, and without glycogen, the protective lactobacilli starve. As the good bacteria die off, the production of lactic acid halts.
And then the pH rises.
Rapidly. The pH of the environment rapidly rises, neutralizing that chemical shield and leaving the area highly vulnerable to chronic infections.
But beyond just the infection risk, the physical texture of the tissue fundamentally alters too, right? Like the sources describe the tissue becoming severely dehydrated and just losing its elasticity entirely.
Yes. Clinicians use the term friable.
Friable.
It means the mucosal tissue becomes so delicate and brittle that it tears, microabrades, and bleeds from even the slightest daily friction or movement.
So this brings the architectural nightmare into full view.
It really does.
Because we established earlier that uncross-linked HA is the perfect biological payload for this problem. The tissue desperately needs the massive hydration reservoir, and it desperately needs the fibroblast signaling to rebuild the extracellular matrix.
Desperately.
But you absolutely cannot use the NAPPAGE technique to deliver it here.
It would be a clinical disaster. If you take a sharp 30-gauge needle and attempt to make 60 distinct punctures into a paper-thin, friable mucosal layer that is already tearing on its own, you are no longer aerating a lawn. You are taking a spiked rake to wet tissue paper.
Oh, that sounds awful.
You would completely shred the mucosal surface, causing immense pain, bleeding, and further architectural collapse.
You would basically destroy the terrain trying to fertilize the soil.
Exactly.
So what does this all mean for the practitioners? How do you hydrate and rebuild paper-thin tissue without touching the fragile surface?
Well, this specific challenge led to the development of highly specialized injection protocols designed strictly for genital well-being and mucosal rescue. And the most prominent one is the Deserial method.
The Deserial method, okay.
And the first mandate of this protocol is the complete abandonment of the 30-gauge needle and the multi-puncture approach.
So they throw out the lawn aerator entirely. What tool do they use instead?
Practitioners switch to a much longer, thicker instrument known as a 25-gauge cannula.
Okay, for someone listening who might not have spent time in a medical supply closet, what is the functional difference between a standard needle and a cannula?
It's a huge difference. A needle is rigid and its tip is beveled, meaning it is cut at an angle to create a microscopic, razor-sharp blade. It's designed to slice through skin and blood vessels.
And a cannula.
A cannula is a flexible, hollow tube with a completely blunt, rounded tip. It is not designed to cut at all. It is designed to push.
And where are they putting this blunt tube? Because they can't target the superficial dermis like they do on the face, right? There isn't enough superficial tissue left to hold the liquid.
Right, so the practitioner bypasses the fragile surface entirely and targets a much deeper, vastly safer anatomical layer called the submucosal plane.
But how do they get a blunt tube down there without making 60 holes?
The genius of the protocol lies in the entry point. Instead of 60 tiny stabs across the whole compromised area, the practitioner creates just one single, very small entry point.
Just one.
Just one. And crucially, they make this single entry laterally, usually just outside the most friable, delicate areas of the vaginal vestibule.
Geographically speaking, they are stepping away from the danger zone, making one tiny doorway in slightly tougher tissue and sliding the long cannula in from the side.
Exactly. And as the blunt tip of the cannula slides deeply underneath the delicate mucosa, it doesn't slice through the microscopic blood vessels or the nerve endings. The rounded tip gently pushes those vital structures out of the way, creating a safe, temporary tunnel deep in the submucosa.
It's brilliant. I have another landscaping analogy, but I think it tracks perfectly.
Let's hear it.
So if the photo-aged face was a sturdy lawn that needed aggressive aeration from the top down, treating atrophic mucosa is like realizing your topsoil has turned to dust and is blowing away in the wind.
Right.
If you step on it or rake it, you destroy what little is left. So instead, you carefully thread a flexible soaker hose deep underground, completely bypassing the surface. You deliver the water and the fertilizer straight to the deep foundation without ever disturbing the fragile dust above.
The physics of that analogy align perfectly with the clinical technique. Through that deep cannula, the practitioner distributes much larger microboluses of the uncross-linked HA, usually in 0.05 to 0.1 milliliters at a time, depositing it smoothly directly beneath the vestibule and the posterior commissure.
And because it's a single entry point from the side, when they pull the cannula out, there are no visible bumps, no papules, No trauma to the surface tissue.
None. The surface remains totally intact. Once the cannula is withdrawn, the practitioner uses external compression, so performing gentle molding and manual massage to ensure that the liquid HA spreads out evenly within that deep submucosal plane.
And because the liquid is placed so deeply, the hydration process basically happens in reverse compared to the face. It starts plumping the tissue from the bottom up.
Yeah, and more critically, it provides that deep fibroblast stimulation from the bottom up.
Right, the rebuilding.
Exactly. Over the next 2 to 4 weeks, as the enzymes break down the massive HA molecules, those fragments bind to the CD44 receptors deep in the tissue. The extracellular matrix slowly begins to rebuild itself. The collagen network strengthens, local blood flow improves, and gradually the epithelium begins to thicken again.
So it regains its mechanical integrity and stops being so friable, and it achieves all of this without the patient ever having to endure the trauma of 60 needle punctures.
Right.
It really highlights just how adaptable medicine has to be. The payload doesn't change. Uncross-linked hyaluronic acid is doing the exact same biological job in the face as it is in the mucosa, but the delivery system dictates whether the treatment is a miraculous rescue or a catastrophic injury.
It forces us to remember that introducing a compound into the human body is an exercise in architectural awareness. The efficacy of the medicine is forever bound to the limitations of the terrain.
Which brings me to a final, somewhat mind-bending thought for you to take away today. We have spent this entire time looking at how the physical, structural terrain forces us to change our mechanical delivery. But think about the biological domino effect that happens after that terrain is repaired from the bottom up.
Oh, this is a great point.
We know that healthy, robust vaginal tissue creates glycogen, right? And that glycogen is the sole food source for the lactobacillus that maintains the acidic protective microbiome.
The implications of that biological loop are profound.
If injecting uncross-linked HA via a deep cannula mechanically restores the extracellular matrix and physically thickens that mucosal wall, could a purely structural mechanical intervention actually reboot a biological microbiome?
It's a huge question.
We usually try to fix microbiomes with chemical or biological tools, like antibiotics to kill the bad stuff, probiotics to introduce the good stuff. But if fixing the physical scaffolding of the tissue naturally brings back the glycogen, can simply repairing the architecture of the house literally invite the right bacteria back in to live there?
It totally blurs the line between physical engineering and biological ecosystems.
It's an incredible frontier, and definitely something to mull over as you go about your day. Until next time, keep digging deeper.